before I start, I'd like to thank Professor Ülkemiz
Azhar,
for inviting me.
microphone should be working.
Before I start, I'd like to thank the organisers of this conference, particularly Professor Ülkemiz, the university, and the Gaziantep Family Doctors Association for inviting me. It is a real pleasure and an honour to be here in Turkey. As you can see, I work in the United Kingdom, but my family originate from Pakistan. And before I came, I told my dad that I was coming to, my father, that I was coming to speak in Turkey, and he was very pleased. He said that Pakistan and Turkey are very good friends, so I'm really happy to be here from that point of view as well. Okay, what I'm going to talk about to you today is to describe the healthcare system in the United Kingdom, particularly how it has evolved over the past 30 years. And hopefully there may be things that I say that might be helpful to you as your own health system develops and improves in the coming years. Let me tell you a little bit about general practice in the UK. One thing about the UK is that every citizen in the country has to be registered with a general practitioner. They have to have their own family doctor, and it's their right to be registered. And the average GP in the United Kingdom has 2,000 patients. So for example, in my practice, there are about 8 doctors. So we've got 14,000 patients that we look after. And those patients we look after from the time they're born, if we're there long enough, to the time that they die. They are with us for their whole life. Doctors are organised in group practices, so most doctors, they work with 3 or 4 other doctors. And the other thing in the United Kingdom is that patients cannot go to hospital or see a specialist without first seeing their GP. Unless it's an emergency and they get taken in an ambulance, they cannot see a specialist unless their GP refers them. So that's a very important difference. And in the UK, 90% of the contacts with patients are done by GPs. The vast majority of care is provided by GPs, and specialists provide about 10% of the care. And in the GP, the system is completely free. Patients do not pay for any care really. Their drugs are free, their doctor's fees are free, hospital treatment is free, so there isn't any cost to the patient. And this is the reason why we have GPs as the gatekeepers, so we decide when patients need more expensive care in the hospital. So why is diabetes so important, and why are we here in this conference? Well, it's a big problem all over the world, as we heard earlier. So in the UK, we've got almost 3 million people with diabetes. The prevalence is around 5 to 6%. But in certain communities, particularly in immigrant communities, it can be as high as 10 or 12%. And in the elderly population, it is very high as well. We have over 6 million people in the UK who are at risk of diabetes. So we expect that number of 3 million to rise dramatically. I can get the pointer to work. Oh yes. That 3 million to rise dramatically to maybe 6 or 7 million in the coming years. Diabetes is a lifelong disease. In our country, it consumes 10% of the health budget. Around about £10 billion a year is spent on diabetes. And it's the largest cause of blindness, renal failure and amputation in the UK. This slide here also tells you why diabetes is important. This is quite an old slide, data about 20 years ago from the UK, and I'll give you some more recent data later. But what this slide shows you is that if you have diabetes, your life is reduced by 10 to 15 years, depending on what age you're diagnosed. So it's an important condition. So what I'm going to do is give you the story of diabetes in the UK, particularly with reference to general practice. I've been a GP for 25 years, so I've seen quite a lot of changes over that time. And there's been a revolution in primary care services in the United Kingdom. And I think this revolution will be followed in other countries in the future. So I will describe the changes in the 1980s, when I first started as a young doctor, in the 1990s, and then 2000 and beyond. So those changes I'll describe and how they have improved healthcare for patients. One thing that I ought to say at this point is that the changes, the improvements, the majority of the benefit for patients has not been about new drugs or new treatments. In the 1980s, most patients were on insulin, they were on sulfonylureas and metformin. And even today in the UK, the majority of patients are on insulin, they're on sulfonylureas and they're on metformin. I know there are new drugs which may have quite a bit of benefit in the future, but most of the improvement in care has not been about drugs, it's been about improving how we look after patients. So this is my clinic. I work about half of my week I work in the clinic, in the other half I work in the university and in organising the local healthcare system. And when I joined in the 1980s, we had no diabetes register in our practice, so we did not know which patients out of the 13,000 that we had diabetes, and we had no clinics for diabetes at all in the practice. So the question, even in the 1980s, people were asking, where should diabetes be looked after? Should it be looked after by specialists, or should it be looked after by general practitioners who are close to the patient? And there were two studies in the 1980s which I want to describe to you, which I think helps give the answer to this question. The first study is the one on the left by Hayes and Harries in Cardiff, this study here. In this particular study, the hospital took 200 of their patients that were attending the hospital clinic, and half of them, they said, we don't want to see you anymore, go back to your GP. And half of them, they continued to see in the hospital. And what they found after 5 years is that the patients in general practice had much worse hemoglobin A1C. So they had 10.5 as opposed to 9.5 in the hospital. There was much higher mortality in primary care, and of the patients who were discharged back to primary care, only 13% were actually seen by the GP. So in other words, they went back, but the GP didn't even see the patient regularly. So this study seems to show that if specialists tell their patients to go and see their GPs, their care will be terrible. They won't be looked after properly. I'll now describe to you a second study conducted about the same time in Wolverhampton, which is a different city, by Dr. Singh in Holland. And in this study, they also discharged their hospital patients, but this time they discharged them to practices who had been trained to look after diabetes. So these practices, these general practices, had proper clinics. They had the GPs who were interested in diabetes and GPs who ran proper clinics. And in this situation, the patients did just as well as the patients who were in hospital. In some instances, they did even better. So what this study showed, that if practices can organise their care properly, they can offer just as good care as hospitals. And in fact, there's been a lot of studies, and this is a graph of a number of studies looking at general practice versus hospital care. And what it shows is that practices who are well organised can offer as good or better care than specialists for the majority of patients. But the important thing is that practices must be well organised and they must know how to look after their patients with diabetes. This is another study from Sheffield, which is another large city in the United Kingdom, where more than 400 patients were discharged from hospital back to general practice. And what they found was that many patients, when they were discharged, thought, oh, my diabetes is better, I don't need to see anybody, because the hospital doesn't want to see me. And many patients did not bother to go to their GP. So again, this study showed that it's not about where you go, it's about how well the care is organised. So in summary, this was the situation in the 1980s. Management of diabetes, particularly type 2 diabetes, was not really great in those days. The average hemoglobin A1 of all patients was around 10% in the UK. And hospital care was superior to general practice, and the main reason for that was the GPs were not well organised. And because of that, really, at that stage, if you were a diabetic, it was probably better for you to go to hospital than to your average GP. So, we realised and understood this situation, so what we tried to do was to improve general practice, so that in future, more patients could be looked after in the primary care setting. So the way we did this is by looking at clinical audits. And this is really around helping practices to evaluate their own care, to look at the care they're providing, and to try and improve it. And also to make sure that they implemented the best evidence for diabetes care, which was emerging then with studies like the UK PDS study. At the end of the decade, in the 1990s, we had quite a few developments, which I'll describe in a moment, which also helped general practice to deliver much better care. So, in Leicester, where I work, I and colleagues introduced a diabetes audit program in all our general practices. And this was around getting practices to look at their care, to see what level of care they were providing and how they could improve that care. And what we did, we used this as a very, very powerful tool to drive education of healthcare professionals, and also to make sure that patients were looked after much better. You might ask, what is an audit? How do you do audit? Well, audit is quite a simple process. What you do is you look at all your diabetic patients at one point in time, and you assess how well you're looking after them. So, for example, you might look at, do they come for their annual check? What is their hemoglobin A1C? What are their lipids? What are their blood pressure? Have they had their foot examined? Have they had their eye screened? So you do this, and you do this and see how you're performing. You then look to improve that by changing your practice. So, for example, if your hemoglobin A1C is 10%, you want to improve that. So you look at what else you can do. Review the patients more frequently, use better medications, better patient education to try and improve that. So we've got all practices to do this audit cycle, which is around setting standards, seeing how their performance was, and then reviewing to see if they can make changes to improve that performance. And this is some of the data that we've had from practices. We published this in major journals in the UK. I was one of the authors of this particular study with other colleagues in Leicester. And what we found is that practices who did this audit improved significantly. So if you look, for example, here at where the patients had their urine checked, it went up from 67 to 74% in these practices. And all the other parameters, whether it's checking of their hemoglobin A1C, their blood pressure, their lipids, it all improved in practices when we did this particular process. So by the end of the 90s, we had actually improved care in primary care significantly. Most of our practices now had a diabetes register. Increasingly, practices in the UK were being computerised. So at the touch of a few buttons, they could find out exactly how many diabetic patients they had. They could find out what their control was like, what their blood pressure was like, what their lipid levels were like. And what we found is by the end of the 90s, practices were now starting to put these systems into place. Most practices in this group of 30 practices here had diabetes registers. Nearly half of them now have call-in recall, which means if a patient didn't come to see you, you wrote him a letter, or you rang the patient, or you sent the nurse to see the patient to make sure they had their check. And more practices were now running formal diabetes clinics as well within the surgery. So, by the end of the 90s, we now had clinical audit in our general practices. The practices were actually looking at their diabetes care. They all had registers of their diabetic patients, so at any one time they could tell you how many patients they had with diabetes and what their control was like. They all had computers, so if a patient didn't come for care, they could follow that up. And they were all starting to demonstrate significant improvements in care. So we were moving from the 80s to the 90s. There was starting to be quite a lot of improvement in patient care. So, moving on to the next decade, which is the 2000s. What happened in the UK to further improve care? Well, there were a number of big developments in the UK at that stage. which have really helped improve diabetes in primary care. First of all, we had a national strategy for diabetes published. This was published by the Department of Health, who decided the level of care that all patients in the country should get for their diabetes. So there were things like everybody should have an annual check. Everybody should have retinal photography or retinopathy every year. Every patient should try to get their hemoglobin A1C to below 7.5. So there were all these standards were established. We also had at that time national clinical guidelines through our NICE organisation, and we've now had a system where GPs could get payment for good quality care in diabetes. So in other words, if practices, GPs provided good care, they would get extra money from the government. So all these things were really very helpful to improving patient care. This is the national strategy that we published in 2001, and I was one of the authors of this document. And we've got here a list of the standards that the government decided for diabetes. They include prevention, early detection, good clinical care, includes good care for children, good care while you're admitted to hospital, in pregnancy, and in the management of complications. So all these things were defined as national standards. And then in terms of payments, each GP in the country, if they could demonstrate that they were offering good quality care, would get an extra payment of £5,000 per GP. That's about 15,000 Turkish lira. So that's in addition to their existing pay. So this was additional pay. So there was a big advantage now for practices to start looking at their diabetes care. So practices started to set up registers, make sure they had annual review, put an eye screening, TP, lipid, hemoglobin A1C. Because if they did this, they would get the extra payment. If they didn't do it to a high standard, they would not get this payment. And what was the impact of this extra payment for practices? Well, it's quite dramatic. Before the payment in 2006, less than 40% of patients in primary care had a hemoglobin A1C of less than 7.5. By 2010, that had doubled. It was more than 2/3 of patients. In terms of total cholesterol, in 2006, only 72% of patients had a total cholesterol less than 5. Now, it's well over 90%. It's 88% there, but it's well over 90%. So this shows if you have a strategy, if you fund primary care, if you try and train primary care, you can really get high standards of care. We also had primary care doing screening. And this was a project I led, I was one of the leaders back in the 90s, where we encouraged people to be screened for diabetes. So, for example, we had a bus that went around Leicester, and patients could go on the bus and have their blood glucose measured. But we encourage practices to do more and more screening. As a consequence, our pickup of diabetes has improved dramatically. So in 1980 we had 800,000 diabetics in the UK. In 2010 we had almost 3 million. And most of that has been picked up by general practitioners. And in fact now, the actual prevalence of diabetes compared to the expected prevalence, in other words the missing patients, now is relatively small. We've got small numbers of missing patients. We've diagnosed, probably 2/3 of the patients out there have now been diagnosed. So, we're moving on now to the current decade, 2010 and beyond. Does hospital care still have better outcomes? Because if you remember in 1980 I showed you data that if patients were discharged from hospital, they would get less good care compared to in general practice compared to hospital. So I'm going to describe a study to you now that we've done really in the last few years called the EDITION study. And this was an international study where Leicester was one of the sites. It also took place in Cambridge, in Denmark and in the Netherlands. And what this study involved was detecting patients with diabetes through screening and then randomizing them either to intensive hospital-based management, where they went to the hospital every month to have their diabetes controlled, or just to have their usual care in general practice. And if you look at this slide here, this is routine general practice care. And if you look at hemoglobin A1Cs for these patients after several years, was 6.5% in general practice. But in the intensive care, where they went to the hospital every month and saw a specialist, it was only 6.6. So the GP group were actually doing better. And same with their blood pressure control. Really, there was no difference between hospital and general practice. So I think what this slide tells us is all the work that we've done in the UK in the 80s, the 90s and in the 2000s is now resulting in much better care for patients. In fact, for these group of patients, and I'm not talking about complex patients or patients with a lot of complications, but people who are detected early with type 2 diabetes, general practice can offer as good or if not better care than hospital. That's the data there. Okay, earlier I showed you a slide that people with diabetes are losing 10 to 15 years of their life. And that was data from the 80s and 90s. We look now, in fact, that has improved radically. So instead of the red line, the gap now is between the yellow and the green line, not between the yellow and the red line. And now that gap is 10 to 15%. And the reason for that is because we are managing diabetes much better. Not just their glycemic control, but their lipids, their blood pressure is really being managed so effectively now that this life expectancy gap is reducing very rapidly. And it just shows what you can do for patients if you intervene early and manage them effectively. This slide here I will show you as well. I'm sorry the colours are not very clear, but this pink area is the reason why people with diabetes die, both for men and women. And the pink area is vascular deaths. So people with diabetes, they die of vascular disease, they die of heart attacks, and they die of strokes. So the other message I say to you, particularly for you who work in general practice, is that glycemic control, although it's important, isn't the most important thing for many of these patients. What you really need to do is to control their blood pressure and control their cholesterol, because that's the way you're going to reduce cardiovascular death. And I think death rates in diabetics are falling because we are treating the metabolic syndrome and not just glycemic control. Lipids and blood pressure are really important, so that's a message that really you must not forget. So, in terms of a summary, in terms of where we got to by 2010, the fact that we had a national strategy in the UK was very, very important. The fact that we had specific payment for primary care to look after people with diabetes also had a big impact. And to conclude, primary care is really showing evidence that it's managing diabetes, particularly type 2 diabetes, very well. So what are the problems for the next decade, moving on towards 2020? What are the issues we face in the UK? Well, we still face variability. One practice can be very good, and a practice down the road may not be so good. So we have variations still that we need to address. We still have a lot of work to do in terms of empowering patients. Because if you're a diabetic, how many times a day, how many times a year do you see a doctor or a nurse? Maybe 2, 3, 4, 5 times a year. The other 360 days, you have to look after yourself. So we really need to do more work in terms of patient endowment, and I know Heather will be talking, I know Heather will be talking about that later. And we need to make sure that we commission services for diabetes so they're provided to a high level. Now I'll just explain what I mean by commissioning, because in my particular area I'm one of the leaders in commissioning. What we have the budget for healthcare, and we decide how that money is spent. And we have to spend it effectively. We have to spend it in the place where it will benefit patients most. So for some areas, we have to spend it in the hospital, because the hospital can do some things very well. But for other areas, we have to invest that money in primary care. And if we've got diabetes with a prevalence of 10 or 13%, as you have in Turkey, you've got to invest in primary care. Otherwise, you're not going to prevent diabetes, and you're not going to manage that big group of patients with type 2 diabetes who really will probably never go to a hospital for many years. So these two slides here just show that we still have a lot of variability. This slide here is around how effectively patients are managed, and the light blue areas are very good, the dark blue areas are half as bad. So you can see within England there's huge variation. And this is around amputation rates. Again, some areas have double the amputation rates of other areas. So there still is variability, and we need to address that. I'm sure there's variability in Turkey as well. There's variability depending on your ethnic group. So in the UK we have a large ethnic minority population, many of them from India and Pakistan. They get much worse care than white patients. So we need to look at how that care is provided as well. And even within how wealthy people are, better off people who are wealthy get better care than poor people. These are issues we still need to address in the UK. Structured patient education is something that we're really developing. We've done a lot of work. This is a project I was involved with looking at heart disease, where we educating patients how to manage their own cholesterol and their blood pressure problems. And we now have got a Desmond program, which again Heather will talk about, which is around education for patients with type 2 diabetes. They go on a special course so they can learn about their disease and learn how they can manage it better. So commissioning diabetes. This is around ensuring the taxpayer, i.e. the people who fund the health service in the UK, get the best value for their money. That's what commissioning diabetes is about. And we've got quite a few documents now in the UK as to how we can do that effectively. Those are two there. So the way that we are commissioning diabetes in my area now is illustrated by this diagram here. This blue setting here is the primary care or general practice setting, and it's a big circle because that is where we expect most diabetes care to take place. The pink circle here is the hospital sector. Important because these are very sick patients and patients with complications, but it's a much smaller area in terms of where diabetes care takes place. So this is how we are investing our resources, more and more in primary care, but making sure that the hospital does the work that it's really good at. And this is how we divide the role of generalists and specialists in the UK. Generalists do these activities. They do screening. They do work on prevention. They do work on regular surveillance, regular review. They do all the prescribing in the UK happens in primary care. Insulin initiation, particularly for type 2 diabetes, is in primary care increasingly, though type 1 still is in hospital. Patient education happens in primary care and general practice. Cardiovascular risk reduction, treating people's blood pressure and lipids. This is something that GPs should be doing. And because they see more patients, in many ways they're better than specialists in doing that. People who can't get out of their home, for example, if they're in a nursing home or if they're very elderly, they can't leave their home, that's the job of primary care as well. And measuring outcomes and audits. So all these things we fund primary care to do. What about the specialists? Well, we have defined 7 tasks for the specialists. These are called the Super 7. This is around type 1 diabetes, a very complex type 2, pediatrics, pregnancy, managing complications such as renal problems, foot problems. Those happen in hospital. But we have other roles for our specialists. They are very important in education. So educating GPs, educating nurses. We really need our specialists to help us in that area. And research as well is very much a role for the specialists, though general practices can be involved in that as well. So the next area I want to talk about is how do we equip primary care to deliver good diabetes care. It's about organisation, which is important, but it's also making sure our GPs and nurses have the right skills. In other words, they have good diabetes training. And in my area, we've got this project, which is known as EDEN, which stands for Effective Diabetes Education Now. And what we are doing, we are investing in all our general practices. In my area, we're investing £300,000 a year for the next 3 years to educate our GPs and our nurses to deliver good diabetes care. So we are doing things like master's programs. We are doing mini modules. We are doing mentorship where consultants or specialists go into the practice. We are doing healthcare assistant training, nurse training. So all these things we're doing to make sure that our practices can look after patients effectively. So to finish off, in summary, the development of diabetes services is a journey. And every country is on that journey and is at a different stage in that journey. I've described to you the journey in the UK. which has meant that more and more diabetes care is now being provided in primary care. Diabetes is a chronic condition. You have it for life. It really is a condition that I would say, unless there are special problems, needs to be delivered by primary care. But this requires good IT systems so that GPs can monitor what they're doing and make sure that they're providing good services. It needs education for professionals, so the health department needs to make sure their GPs and primary care teams are educated. And I would argue, and we're finding this in the UK, that a primary care-based model is the only way that we can deliver good diabetes care to all the population, not just a part of it. We have a duty to all the population. So if you have 13% diabetes in Turkey, you have a duty to all that 13% to give them good care. And that can only be done if general practice does that to a high level. So I'd like to finish there. Thank you for listening.